Can everyone see the screen? Hello?
Yes, Doc, we're seeing the screen.
All right, great. Good morning. So we're going to talk about strabismus. And this is just a pre-test. One second. All right. So we just do a little pre-test. Don't worry if you don't have the answers right. Just look at the questions, and as we go through the lecture, you should be able to answer these questions, but there should be some questions that you can answer right away. Can anyone tell me the answer to question 1 before I pick on anyone?
I know lateral rectus is 6, medial is 3, and I think superior rectus is also, I think, is the superior division of the oculomotor as well. I'm not quite sure about D. I don't remember D.
All right. Well, that's good. So you have some idea as to where we'll start and where we'll go. Do you have an idea what's a squint?
The only thing I can think of is when you squint your eyes, when you can't really see properly.
All right. All right. Great. All right. Great. So a squint is what we call cast eye, where the eyes are misaligned. All right. So the visual axes are misaligned. So both foveas are not aligned on the object being viewed. So if someone has a squint and they're looking at you, you're kind of trying to find out, are they looking at me or are they looking across the road at something else? Because the eyes are misaligned, all right? Sometimes it's quite subtle. As we can see, sometimes you have some prominent actors and actresses who have mild misalignment of their eyes. So we're going to go over the definition. We're going to do a little anatomy of the extraocular muscles. We're going to classify strabismus, which is important. We're going to do some tests for strabismus, including the Hirschberg, the Krimsky, the cover and uncover test, and the alternate and prism cover tests. And when we're going to evaluate and manage these patients with strabismus. So at the end of this lecture, you're going to be well versed on the topic, all right? So let's talk about the eye. As you can see here, the eye has 6 extraocular muscles. There are 4 recti called the medial rectus, the inferior rectus, the lateral and superior rectus, and 2 oblique muscles, the inferior and the superior oblique. This is just showing that the distance that the recti insert from the limbus is different. So this is the limbus right here. So medial rectus inserts 5.5 millimeters away, and this is just how they insert, and these are your oblique muscles, okay? So where do these recti originate? They originate from a fibrous band called the annulus of Sin, and this is more or less in the apex of the orbit. And this is just to show how interesting it is. They all originate from this one common tendinous sheath. So the innervations of the medial rectus is the 3rd cranial nerve, lateral the 4th, superior rectus, inferior rectus, and inferior oblique are also the 3rd cranial nerve, and the superior oblique is a 4th cranial nerve, lateral rectus a 6th cranial nerve. So each of these muscles will pull the eye in a certain direction, and we're going to talk about these, how they move the eyes. Medial rectus will adduct the eye, which is moving it towards the nose. Lateral rectus will abduct, taking the eye away from the midline. laterally. Superior rectus will elevate. It will also adduct and encyclotort. Inferior rectus mainly will depress, and it will also adduct. The obliques will tort the eye, either encyclotort or excyclotort. So let's go over this. So we can talk about the action of the muscle, which is the effect of the muscle contraction on the rotation of the eye when the eye is in primary position. The horizontal rectus muscles will move the eyes horizontally, and the vertical recti and the obliques have vertical, horizontal, and torsional movements. The field of action of the muscles is the position of the eye when an individual muscle is the primary mover of the eye. What do I mean by this? Let's talk about ductions first. In figure A, that's a primary position, looking straight ahead. B, we have adduction, where the eyes move towards the nose. C will be abduction, where the eyes moving out the nose. So if you think of here as the nose, adduction towards, abduction it's going away, superduction is going up, infraduction is going down, intorsion, and extorsion. All right, everyone got that? All right, so the field of action. This is a very important slide because it will help you to, we use this quite a lot in ophthalmology. So with the field of action, the rectus, the superior rectus elevates the eye. All right?
Good morning, Doc.
Good morning.
So, I think there is a feature on the top left-hand corner, arrow, in case you want to use that instead of keep coming out of the.
Yes, yes, I know we can do that, but all right, tell you what. It's because of how I'm sharing, because of the size of the slides. There's an arrow if I had put the slides in the
Oh, okay, understood.
blackboard. That's what I explained earlier. All
Okay.
right, sorry about that. But can you see this arrow here?
Yes, sir.
All right, so just bear with me. The slides are a bit big, and so your application couldn't accommodate them. All right. So superior rectus will elevate the eye. The lateral rectus will abduct the eye. Inferior rectus will depress the eye. The obliques act to adduct the eye, as well as the medial recti. So when you look at your positions of gaze, this is just what that's saying. If you look at the upper left-hand corner, you'll see that the superior rectus is moving that eye up and out, and the inferior rectus is moving the contralateral eye up and in. And you just spend some time and review this slide. So your visual axis, or your line of vision, passes from the fovea through the nodal point of the eye to the point of fixation. So if you're in perfect alignment, it's called orthophoria, and heterophoria is a tendency of the eyes to deviate when fusion is blocked, and that's called a latent or a hidden squint. All right? So atropia is a manifest deviation, and images from both eyes are misaligned, and the patient will have diplopia or double vision. The image from the deviating eye is suppressed at the cortical level, and there's failure of normal development of binocular fusion mechanisms, and usually these patients will have a refractive error. There's failure of fusion secondary to poor vision in one eye, and this may cause heterotropia in adulthood. There can be weakness or mechanical restriction of the extraocular muscles or damage of their nerve supply, and horizontal deviation of the eye, whether it be latent or manifest, is the most common form of strabismus. You can also have vertical deviation if the eye is displaced upward. it's called a hypertropia, upward displacement of one eye relative to the other. If it's an imbalance which is controlled in the upward direction, it's called a hyperphoria. A hypotropia is a downward displacement, whereas a hypophoria is a downward imbalance. So how do we classify strabismus? And this is very important. Strabismus can be classified as infantile or acquired, comitant versus incomitant, manifest versus latent, intermittent versus constant, accommodative versus non-accommodative, and then we can classify it based on the direction of gaze, whether it's a horizontal strabismus, cyclotorsional, or vertical strabismus. So if we're classifying it based on the direction of gaze, an esodeviation is a convergent squint, exodeviation is a divergent squint or the eye is turned out. Hyperdeviation, one eye is elevated relative to the other. Hypodeviation, one eye is depressed relative to the other. When we classify it as concomitant or incomitant, we're talking about paralytic versus non-paralytic squints. In a paralytic squint, the angle of deviation is going to vary with the direction of gaze. Whereas in a non-paralytic squint, the angle of deviation remains constant in all positions of gaze. When we talk manifest squint versus latent squint, the manifest squint is one that is going to be present when both eyes are open, and we call these tropias. A latent or a hidden squint is only demonstrable when one eye is dissociated or binocular vision is disrupted, and we're going to show you that in a minute. And a hidden squint is called a phoria. We do quite a bit of things when we evaluate a person with strabismus. We look at the head position, we see how well they're seeing with the eye, and based on the age of the patient, we do different things. We can use a visual acuity chart, but for kids, they can't read. So we give them pictures with animals or things that they may be comfortable identifying. We do what we call preferential looking. They may not be at the age to identify a cat and a dog, but you put an object that's brightly lit in front of them and move it around, and you see them moving the eyes. We look at the corneal reflex, and we call that the Hirschberg test, and we do some other tests as listed here. So let's talk about the Hirschberg test. So in the Hirschberg test, it's an objective estimate of the angle of manifest strabismus. So a pen torch is shone in the eyes from arm's length, and the patient is asked to fixate on the light. The corneal reflex on the light will be centered in the pupil of the fixating eye, but it will be decentered in a squinting eye in the direction opposite to that of the deviation. So the distance of the corneal light reflex from the center of the pupil is noted. And if the light falls on the temporal border of the pupil, the angle is about 15 degrees. If it falls on the limbus, the angle is about 45 degrees. So let's look at and see what I mean by that. So we're talking about a manifest strabismus here. The pen torch is going to be shone in the eye from arm's length, and the patient is asked to fixate on the light. So the corneal reflex will be centered in the pupil of the fixating eye, but it will be decentered in the squinting eye in a direction that's opposite that of the fixation, of the deviation, sorry. The distance of the corneal light reflex from the center of the pupil is noted. Each millimeter of deviation is approximately equal to 7 degrees. So assuming that the pupillary diameter is about 4 millimeters, the temporal border of the pupil is about 15 degrees. And if it falls on the limbus, we say it's about 45 degrees. So there it falls on the limbus, and that's at 45 degrees. So that's a 45 degrees deviation that's shown there versus previously. Right there at the pupillar border, it's 15 degrees. If it's anywhere in between the pupillar border and the limbus, we say it's about 30 degrees, okay? So here we have 3 kids, and we see the first child, the first patient in figure A. Anyone wants to describe what they're seeing there? No takers? All right, so this is a Hirschberg test, and the left eye, we see the pupil, the light is centered in the pupil of the left eye, but we see that this right eye, the light is at the pupillary border. So the eyes turned inward. So we say this is a 15 degrees esotropia of the right eye. When we look at this patient here, we see that the light reflex is centered on the right eye. However, look at the left eye. The left eye is turned inwards as well. And somehow it's the reflex is in between the pupillary border and the limbus, so that's about 30 degrees. When you look at this patient here, this patient has a hypotropia. The light reflex is pretty much centered here, but it's about 45 degrees in that right eye. So another test that we do is called a Krimsky test. And basically what you're going to be doing is placing a prism in front of the fixating eye until the corneal light reflexes are symmetrical. So here we go. We see there's a deviation in this eye. We look at the right eye and we see that there's about a 45 degrees exotropia of that right eye. I hope everyone can appreciate that. And so with the Krimsky test, basically what you're going to be doing is you're going to be putting a prism in front of the fixating eye until the corneal reflexes are symmetrical. So here we go. We're going to be putting a prism in front of the fixating left eye, and then we're going to increase the power of the prism. And as we see, 15 degrees, 25, 35, 45. And at 45 degrees, our light reflexes are symmetrical. And so that's the Krimsky test. We're going to talk about the cover test and then the uncover test. So the cover test is used to detect a heterotropia, which we said is a manifest squint. You can actually see that squint. And the patient, what you ask the patient to do is to fixate on a straight ahead target. And you suspect, as in this patient, that the right eye is the eye that's deviated. So you're going to cover the fixating left eye and note any movement of the right eye to take up fixation. If there's no movement, then the person is perfectly aligned, which we call orthotropia, or there's a left heterotropia. However, if we see the eye moving inwards, the right eye adducts, adducts to take up fixation, then we say the patient has an exotropia. If the right eye abducts, abducts, then the patient has an esotropia. Downward movement, hypertropia, and upward movement would be a hypotropia. And then we're going to repeat the test. So let's see. As we said, the cover test is used to detect a heterophoria. This patient has a right deviated eye, and it's literally deviated. So we assume that this patient has a right exotropia. We're assuming that. So first thing we ask the patient is to look at a straight ahead target. We suspect that the right eye is deviated. We're going to cover the left eye and we're going to observe the right eye. So if there's no movement of that right eye, we say the person is orthophoria, or maybe they have a left heterotropia. Then we look whether the eye is going to move inwards, outwards, upwards, or downwards. If the eye adducts to take up fixation, then we say the person has an exotropia. If the eye abducts, then we say the patient has an esotropia. Downward movements, hypertropia, and upward movement, hypotropia. And then we'd repeat the test on the other eye. So let's look what happens when we cover the left eye. What happened? Let's do it again. Let's cover that eye and we see that the right eye moves inwards. And so we can assume that the patient has a right exotropia. Now forget that you're seeing through the occluder. Normally you cannot see the occluder, and this is a cartoon. So forget what you're seeing behind the eye. All right. That's okay. So we're going to talk about the uncover test, which is to detect aphoria, which is a hidden squint. So the patient fixates straight ahead on a distant target, and you cover the left eye for about 2 to 3 seconds and then remove the cover. If there's no movement, that indicates an orthophoria. If the left eye had moved while it was under the cover, then you'll see a refixation movement while you're removing the cover. An adduction and adduction indicates an exophoria, an abduction and esophoria, an upward or downward movement indicates a vertical phoria. So let's look what happens here. So you're going to cover the eye question with the occluder and observe what happens under the cover. You're not seeing right now what's happening on the cover, so forget that movement you saw. All right. So what happens, you're going to look at what happens when you remove the cover. It's a hidden squint. What did it do under the cover? So when we remove the cover now, what happens? The eye moves outwards. All right. So as we said, if the eye abducts, that indicates an esophoria, which is shown here. So when you remove the cover, the eye moved outwards. So we can say that's an esophoria. All right, someone has a question. Could you please open your mic and say what your question is?
Sorry, Doc, just a quick question. You said so the esophoria just occurs when there's an absence of light.
No. All right, so this is a phoria, which is a hidden squint. All right. So when you look at this patient and when you look at most of your classmates, you will not notice that they have a squint. It's hidden because you have fusional mechanisms. And so what you're trying to do is you're trying to say, okay, do you really have a squint? And that's when you do this test. It's a hidden squint. You don't know that it exists. And then, so what you do, you occlude one eye and observe what happens when you remove the occluder. Okay? So it's called, some people say it's a lazy eye. So you hide that eye away so it doesn't have anything to look at. So it goes into its lazy position. And then when you move the occluder, then it refixates. Do you understand? Was
Yes,
that a
thank you,
little
Doc.
clearer? All right. So that's a phoria, that's a hidden squint. That's not a manifest squint, that's hidden. Most people have a phoria that you'll notice whenever they are very tired, whenever they're ill or slightly intoxicated. I'm not saying you should get your classmates intoxicated to find out, but some people, even though they have a phoria, it is quite hard to find. So we can do what we call an alternate cover test, which is a dissociation test. And this will reveal the total deviation when fusion is suspended, which is what we were discussing just now. So the first thing you're going to do is to perform your cover test and your uncover test. Then you're going to cover the right eye for several seconds, and then you quickly shift it to the opposite eye for 2 seconds, and then back and forth for several times. All right? A patient with a well-compensated heterophoria will have straight eyes before and after the test has been performed. However, a patient who has poor control may decompensate to a manifest deviation. So basically, if you have someone here who you think may really have a deviation there, once you do this test and you cover the eyes alternately, after a while, one eye will turn out suddenly if they are poorly, if they have poor control. The prism cover test is how we're going to objectively measure the angle of deviation on a near or distant fixation and in any gaze position. So really this is the alternate cover test combined with prisms. So first you're going to do the alternate cover test, and then you're going to bring in prisms of increasing strength in front of one eye with the base, well, we say the pointy part or the apex of the prism in the direction of the deviation. So you perform the alternate cover test continuously, and then you bring in stronger prisms. And as stronger prisms are brought in, the amplitude of the refixation movement gradually decreases until no movement is seen, and that's your endpoint. Let's just have a look at how this is done. So the prism cover test is going to combine the alternate cover test with a prism. So first you do the alternate cover test. So you're going to bring in prisms of increasing strength in front of the eye with the apex, which we're going to show you right now. So the apex is going to be pointing, that's the apex pointing in the direction of the squint because that eye was turned out when we started. And then you continually do the alternate cover test while you increase the strength of the prism in front of the eye. And as you can see, the amplitude or how fast that eye was moving is gradually decreasing. So right now we have a 30 diopters brought in. And we continue to do the alternate cover test. And we're almost there. And there we go. We have no movement at this point. And so we can say a 45 degrees prism neutralize this deviation, maximal deviation. And this guides us surgically or other management that we're going to do. With kids, you don't have time to take one prism and put another. So we have these prism bars, as is shown here. And in her left hand, she has an occluder that she's doing the alternate cover test with. And the kid has the target in her hand, and she's being told to look at that target. So let's recap for a minute, just in case I lost any of you. In figure A, we have an esotropia, the eyes turned inward. In B, we have an exotropia, right eye, look at the right eye, it's turned outward. In C, we have a hypertropia, so the right eye is elevated with respect to the left. And in D, we have a hypotropia, where the right eye is downwards with respect to the left. So I'm just going to go through a few examples of esotropia. One of these is congenital esotropia, and we see this in a child before 6 months of age. And they usually have a large angle esotropia. So when you do the Hirschberg test at 30 degrees, it's not going to fall on the pupillary border, it's going to fall in between the pupil and the limbus, all right? And sometimes it's greater than this. They have cross fixation, which means they can use their left eye to look all the way to their right and their right eye to look left easily. They really don't have binocular vision, and usually they will have some amount of refractive error. Either they're farsighted or nearsighted, which needs to be corrected as well. Another kind of esotropia is accommodative esotropia. And this is an esotropia that you see when the patient tries to read or tries to look at something near. We're going to do accommodation in another lecture. But what happens is when you change your focus from distance to near, you have, some people call it a reflex, where your eyes will converge and your pupils will become smaller. Those are some parts of the reflex. But when a person is quite farsighted, they have to do a lot of accommodation when they're trying to look at something near. And sometimes we have certain mechanisms in the eyes, they break down. And so the eye just turns inwards, all right? And for these persons, it can also, they can have a refractive component where if you correct their farsightedness, then you will eliminate it, or you will eliminate part of it, and that's a partially refractive accommodative esotropia. And exotropia is an outward deviation of the eyes, and it's usually acquired. Some of the associations of concomitant strabismus includes problems in pregnancy, such as intrauterine infections or prematurity, birth trauma. Some people have a family history of strabismus, congenital abnormalities, chromosomal disorders, cerebral palsies, ocular defect or disease such as refractive errors, retinoblastoma, cataracts, etc. Concomitant strabismus may be caused by ocular muscle paresis, such as our paralytic strabismus, or you can have a mechanical restriction such as in thyroid eye disease, if you have an orbital floor fracture, or in myasthenia gravis. We're going to talk a little bit more about paralytic strabismus, but this is one you should not miss. For example, this is a third nerve palsy, and as you can see in the center picture, this person, well, let's start from your far left. You can see that the right eye is totally closed. We call that a ptosis. There's a complete ptosis, all right? That eye is completely down, closed. The lid is down. But when you open it, if you look at the eye in the middle and you look at the light reflexes, you realize they're not symmetrical. That eye is down and out, right? You see that that person has an exotropia and it's a little bit down. And there's limitation when you ask that person to look to his left. The left eye moves outwards, but the right eye doesn't. So let's go over that again. So we see that he has a complete ptosis here. When we open the lid, we see that that eye is out and down. When we ask him to look to his left, he can't move this eye, but he can move this eye. So that's a third nerve palsy. We're going to have another discussion on this topic. This can be an emergency, so this is not something for you to not know in an exam. You can also have fourth nerve palsy, and in this case, one eye is usually higher than the other. So we sometimes when you have a squint, the person will turn the head where the eye cannot go. So you'll see them with an abnormal head position. We look at the visual acuity as we discussed. We discussed the Hirschberg's test, where you look at the corneal reflex. We've covered the cover test and the uncover test, the prism test. There are other tests that we will not go over it's beyond the scope of this lecture, but I'll just mention that we use the Lee screen, and for stereopsis and fusion, we use a synoptophore or a Titmus and other tests to evaluate that. So this is just one of the tests that we use in the kids that can just about read the HOTV chart. We can use the tumbling ease. They love this one. You give them a card to point on the animal they're seeing, or if they can tell you the animal, and they really love this picture chart. Sometimes you'll think a child has a strabismus, but they don't. And this is called a pseudostrabismus. And some of the reasons is that they may have a fold of tissue along the medial canthus, which we call an epicanthic fold. The eyes, the interpupillary distance may be wide. It could be that one eye is bulging forward, an exophthalmos, or they could have facial asymmetry. So here's a little child, and he has a medial epicanthic fold on the left, but as we can see, his corneal reflexes are symmetrical. So here's his epicanthic fold, and we can see that his corneal reflexes are quite symmetrical there. Here's another child that his corneal reflexes fall on the same place of the eye, but his interpupillary distance is quite wide. So the goals of strabismus treatment are to maintain excellent visual acuity in both eyes, maintain binocular vision and stereoscopic vision, and we want to prevent amblyopia. What's amblyopia? Amblyopia is a deficiency of visual acuity occurring in an otherwise normal eye. So we examine the eye, and the patient's eye looks quite fine. It's a perfect eye. However, they can't read anything on the chart, or minimal. Or sometimes it's a mild amblyopia where you can't get them to the 20/20 line. You can get them just above the 20/20 line or 2 lines above that, but that's the best you can do, but the eye looks fine. There's no relative afferent pupillary defect unless the amblyopia is dense. So we may classify it as functional, organic, or hysterical. Functional, we have no retinal cause. Organic, may have a retinal pathology, or they may be a hysterical person. So in the management of strabismus, it can be non-surgical or surgical. Or non-surgical, you're going to correct their refractive errors. We can give them mydriatics or patch the better eye and force them to use the eye that's squinting, so we can maintain some development. The eyes continue to develop as you grow up to a certain age. Surgically, we can do strengthening or weakening procedures. So our recessions are our weakening procedures, and our resection are our strengthening procedures. So a recession, we slacken the muscle by moving it away from its insertion. We can also do a disinsertion of the muscle, which we call a myectomy, which we detach the muscle from its insertion without reattaching that muscle. In our strengthening procedure, as I said, that's a resection. So we shorten a muscle to enhance its effective pull, and then we reattach it to its point of insertion. So now we're going to have a little quiz, and if we're not responding, I'm going to have to pick on you guys. So the first question is, what is a squint after all of that? Any takers there?
Any misalignment of the eye?
That's okay, great. And how do we classify squints? A misalignment of the visual axes, because you know you're medical, so you have the sound. You know, how do we classify squints? Any takers? You can just give us one way to classify squints.
That you have esotropia, exotropia, hypertropia, and hypotropia.
Okay, and that would be classifying it based on the direction of the squint. Yeah. Okay. Anything else?
Yes.
Anybody remembers any other way we classify them?
Manifest was manifest and hidden.
That's correct. Manifest or latent. Any other ways we classify squints?
Infantile versus acquired.
Could you say that again, please?
Infantile versus acquired.
Yes, that's correct. All right. So just to remind you, it can be infantile versus acquired, as your colleague just said, intermittent versus constant, accommodative versus non-accommodative, manifest versus latent, and according to your direction of gaze. All right, so what's the innervation of the superior oblique muscle, lateral rectus, inferior oblique? Hey, that's the easiest question. LR6 SO43. You guys remember that from year 2? The lateral rectus is the 6th cranial nerve. The superior oblique is. Have I lost everyone or they gone asleep? Let's see. I'm not hearing you. Let's see who we have here. All right. Dale. Dale, are you up?
Yes, sir.
Yes, you're up. Can you tell me what's the innervation of the superior oblique?
Cranial nerve 14.
I didn't hear that, Dale.
Cranial nerve 4.
Jessica, do you agree?
Hello? Yeah, sorry, I wasn't listening. What was it? LR6, so
The
that's
superior oblique,
abduced,
innervation of the superior
and
oblique.
SO4, so that's trochlea. Trochlea.
All right. The next questions I'm gonna pick some. No, the superior oblique, Chantel, is not the oculomotor nerve, which is the third nerve. So
No,
so
Doctor, I was saying for
Jabari.
the inferior oblique.
Oh, okay. You're saying that's for the inferior oblique. Okay, thank you so much. So the next questions I'm gonna ask Marie, Kazi, Natasha, Haber, Philip Thompson, and Ashley Scott. And if we have another one, it will be Carlos Andrew or Carol Madu. So in that order, all right? Here we go. So the next question, Mommy is concerned about her 4-month-old child. What advice do you have for Mommy? That's her 4-month-old child.
Hello.
Yes, I'm hearing you.
So mommy's concerned about her 4-month-old child.
Yes, which is shown in the Mhm.
Okay, so I would want to do a couple of the test that you explained earlier to see if the child is having any difficulties with the eyes. If it's not the case, then as you mentioned, the flap over the left eye.
The epicanthic fold?
Yes, the fold, sorry. I said flap.
Yes.
I
So
would
does
advise.
this,
Go ahead, Doc.
before you put the child through the test, if you could just do one test, what would it be for this
I
child?
I would do the the reflective test.
Which is the Hirschberg test, which is shown right here. That's correct. And what is it showing?
Well, it is showing that the both eyes are equal in the response to the light.
Yes, the light reflex is at the same place in both eyes. And
Mm-hmm.
therefore, what's your conclusion?
I would conclude that there is no strabismus going
That's
on.
correct. So you can assure mommy that this child doesn't really have a strabismus or a squint or a cast eye, right? And
Right.
mommy would thank you very much because these eyes are so cute. All right. The next three persons are going to take A, B, and C in that clockwise position. Clockwise. Yep. Go ahead. That was very well answered. Thank you. So who is next? Was there Matthew? I thought I picked on a Matthew.
No, that didn't call me, but I'll try.
Okay. All right. Sorry, but go ahead.
The top left, okay. So the his left eye is inward, deviated inward. So I would say it is a esotropia.
Right. So you'd say that's a left esotropia.
Yes, sir.
All right. And you said it's a tropia. Why?
Oh, but, is it because it manifests? It's not hidden?
Right. It's a manifest squint. You just see it like that. So tell me, what test would you do next? This they have done before you go on. They have done the Hirschberg test. Are you seeing that?
Oh, yeah.
And about what degree, how much of an esotropia would you say this patient has?
Is it in between 15 and 45, so 30?
Mm,
So
no.
45. 45
It's
then.
just about 45. It's just
Okay.
about at the limbus, yeah?
Okay, yeah. Yeah, okay.
All right, so what are your thoughts when you see a patient like this? What test
Um,
would you do next?
um, mm, will you do the prism?
All
Um,
right, run into the prism. All right.
yeah.
So so you want to say what would the prism test tell you?
It would measure the angle of deviation.
More objectively, that's
Yeah.
correct.
Yeah.
All right, so you could have done the cover test, right?
Oh, yes, doc, as well, yes.
Right, so you could have done the cover test as well. All right, so if I told, all right, so what do you think are some of the possible etiologies of this picture?
Um, would it be paralysis of
So
the
basically, I'm asking you in another way, how do you classify squints? All right,
oh
do you see that?
oh yes, doc.
So in an exam, you could say, yes, your answer is right, but I want you to flow nice and smooth. I want you to say it may be congenital or acquired, and if it's acquired, it could be a paralytic squint. And then I'd say, what muscle would be paralyzed here? And you'd say,
I would say is it the lateral rectus.
yeah, it could be a paralysis of your lateral rectus, which is supplied by your,
Abducens nerve.
all right. And then I could ask you, we could move on. But so in an exam, I love how you started. You said that you can just start by saying, you know, what I'm seeing here is a photograph of a patient who has a left esotropia, and as shown here is a Hirschberg test, which is showing that it's approximately X degrees. My differential diagnoses include that this may have been a congenital or acquired, and if it were acquired, it could be XYZ. Another way to, and I'll ask you, are there any other ways to classify this? And you could tell me then, yes, it could be a manifest squint as we see here, or it could be latent, and then you could continue. All right, great,
Oh,
thank you so
yeah,
much.
yeah,
All
no problem.
right, who is next? Do I need to pick on someone else? Let's see. Mark Rampersad. Okay, so Mark, can I hear your thoughts on the second photograph there, which is a little boy?
Hello?
Hello?
Hello? Can you hear me?
You're very low.
Can you hear me now?
Yes, slightly, but go ahead.
Okay, so from the picture I see exotropia in the left eye.
Yes.
Um it seems to be deviated at an angle between of 30 degrees because it's not on the limbus and it's not.
Okay, wonderful, wonderful. All right, so I'm still with you. So tell me, what test would you like to do next?
I
So
could
there's
do
a
a prism
manifest
test.
squint, right?
Mm-hmm.
So if it's a manifest squint, what test would you like to do next?
I can't remember the name of it, but you can alternate between the eyes to see if it's accommodated.
So if we do the cover test and I cover the right eye, what do you expect to happen to the left eye?
I expect it to take a more central position
To do what? Sorry?
to get more into the center
To
or
move
go
inwards,
inwards.
right? And once it does that, it confirms what you said you thought, that this is an exotropia, right?
Mm-hmm.
You understand that?
Yeah.
Yeah. Hey, that's very good. All right. And here we have another kid. We saw that this eye is turned inwards on the right, so we have a right esotropia. And if we covered the left eye, then the right eye will abduct to take up fixation, and that would confirm our diagnosis. All right. I hope that was very interesting. I hope you guys learned a lot from your first day in ophthalmology. Do we have any other questions? Any other questions from the group?
Doc, I wasn't here for the first like 4 minutes, so was it like any suggested reading material, any textbook specifically?
Right. Okay. So there are a couple books that it's going to be listed in your syllabus, lecture notes, and ABC for the eyes. But this wasn't the orientation portion of your lecture. So
Oh,
I've asked your group leader to put his contact information, and Dr. Swaby is gonna get in touch with you and give you some more information. All right?
okay. All right. Thank you,
All
Doc.
right. You're welcome. Are there any other questions? All right, guys, I think you grasped the concepts that I was trying to explain to you today. And it's just about reading it again and you will be fine. Thank you so much for your attention. I think you all will do very well in your exam.